Background: insurance systems, scientific journals, professional groups, educational initiatives, regulatory bodies, and organization of services appear to be fixed in 19th century diagnostic metaphors for psychosis, providing natural protection against change. Furthermore, the existence of two separate diagnostic systems in psychiatry, DSM and ICD, produces a bias that is conservative rather than anti-conservative, reducing the probability of non-cosmetic change. Methods: a qualitative review of the validity, usefulness, and acceptability of the diagnosis of schizophrenia, in order to assess possible discrepancies between actual diagnostic practice in mental health services and alternatives dictated by scientific evidence and societal developments. Results: a 21st century concept of psychotic disorder should refer to an experience that can be understood as a variation of normal human mentation that can be expressed quantitatively. For the purpose of diagnosis, use can be made of scientific evidence of specificity yielding high diagnostic likelihood ratios rather than evidence of weak mean differences yielding low diagnostic likelihood ratios. In the case of psychosis, the evidence appears to favor a syndromal system of classification combining categorical and dimensional representations. The concept of salience has the potential to make the public recognize psychosis as relating to an aspect of human mentation and experience that is universal. Conclusions: the debate about alternatives to diagnose expressions of psychosis is often misunderstood as a misguided attempt to change societal stigma. In reality, however, it is about reduction of iatrogenic stigma, occasioned by the use of unscientific and mystifying terminology. Scientific and societal developments have largely caught up with diagnostic traditions applied to psychosis phenotypes, and although the traditional diagnostic system is deeply ingrained in all aspects of clinical and academic activities, change is possible if professional bodies actively promote a modern system of evidence-based diagnostic practice. Insurance systems, scientific journals, professional groups, educational initiatives, regulatory bodies, and organization of services appear to be fixed in 19th century diagnostic metaphors for psychosis, providing natural protection against change. A literature search was conducted focusing on the topic of diagnosis of psychotic disorders, with special reference to the diagnostic category of schizophrenia, and focusing on evidence of natural phenotype, validity, usefulness, and acceptability. The diagnostic categories of psychotic disorder show overlap in genetic liability amongst themselves, Kendler et al. 1993, and with bipolar disorder, Cardno et al. 2002a, Craddock and Owen 2007, Lichtenstein et al. 2009, suggesting a broad underlying liability that is expressed across the different categories. Within this cluster of psychotic disorders, the term schizophrenia is applied to a syndrome that is characterized by longer duration, bizarre delusions, negative symptoms, and few non-affective psychotic disorders. Schizophrenia, schizoaffective disorder, schizophreniform disorder, delusional disorder, brief, psychotic disorder not otherwise specified. There is evidence that at the level of the general population, positive and negative experiences of psychosis are more loosely associated with each other than at the level of clinical disorder due to the phenomenon of morbidity concentration or Bergson's bias, Merrick et al. 2004. This is the phenomenon that if both positive and negative symptoms each independently contribute to the risk of developing need for care and subsequent receipt of treatment, diagnosed patients in treatment will always display more comorbidity. Figure 1. As argued before, Brockington 1992a, Kendall and Jablensky 2003, Vanos and Verdu 2003. There is no consistent evidence for specificity in terms of symptoms, etiology, treatment, and prognosis between diagnostic categories such as, for example, schizophrenia, bipolar disorder, brief psychotic disorder, schizophreniform disorder, substance-induced psychotic disorder, NOS, delusional disorder, and psychotic depression. It has been suggested that to the degree that these phenomena are not caused by positive symptoms, affective symptoms, cognitive impairment, antipsychotic extrapyramidal side effects, experience of stigma, social exclusion, environmental deprivation, or other treatment, and illness-related factors, they may represent primary negative symptoms as expression of a disease entity within the schizophrenia syndrome, Carpenter et al. 1988. As explained above, the evidence suggests that the natural phenotype for psychosis is dimensional, with different domains of distributed positive-negative disorganization, depressive, manic, and neurocognitive symptoms that are continuous with normal mentation, and relatively nonspecific with regard to traditional diagnostic constructs, or at least not specific enough to be of diagnostic value. There is evidence that changes in distinct psychopathological dimensions during treatment independently and differentially influence outcome. Van Os et al., 1999a. In conclusion, correlates of current diagnostic categories of psychotic illness are not consistently specific in terms of classic validation criteria. Robinson Goose, 1970. Although there are mean differences and some differences that suggest a degree of diagnostic specificity, these are not consistent, and categories in reality represent fuzzy sets blending into each other, just as the symptoms that make up the categories are fuzzy in terms of being continuous with normal mentation. The challenge for DSM-V and ICD-11 is to make use of the evidence suggesting specificity, such as the relative specificity of manic symptoms and the relative specificity of developmental impairment between bipolar disorder and schizophrenia. Murray et al., 2004. While at the same time acknowledging that in many other areas of validation no specificity appears to exist.